I've worked in the field of suicide research for over 20 years now, and I'm a researcher, not a clinician. My research has been focused on psychological autopsy studies of suicide in people of all ages, but I focused on youth suicide because that was a particular issue in New Zealand at the time that I started the study. I also have done studies of people who've made medically serious suicide attempts, and I've followed those people up over time. I'm currently doing a 20-year follow-up of 300 people who made medically serious suicide attempts to look at their outcomes. Having done the psychological autopsy studies and the suicide attempt studies, I then looked at studies of people and families bereaved by suicide, and then helped establish a national bereavement support initiative. And I was also instrumental in establishing a national suicide risk and monitoring program for all children who come into contact, not necessarily just residential contact, but all children who come into contact with child welfare services. Because the research that I've done both on a longitudinal study, a birth cohort study of child and young adolescent development, as well as the psychological autopsy studies of suicide, have suggested that though that population of young children in contact with child welfare services are the most vulnerable to suicidal behaviour. So my work, when I started out, there was not as much known about the risk factors for suicidal behaviour as we now know, and my focus has changed over the years to now translating that risk factor evidence into programs that are effective for suicide prevention. I'm particularly keen that these programs, that the funding for these programs, which are potentially effective, includes money for evaluation. I think that's absolutely mandatory. It's very appealing, intuitively appealing to policymakers and politicians to fund programs and to be seen to be doing something about the issue of suicide. But too often the funding horizons and the politicians' horizons are much shorter than we actually need for evaluation, and I think evaluation tends to get dropped off because it's too difficult. But there's a limited amount of funding for suicide prevention, and I think we have to do the best we can to get evidence to inform the policymakers who are effectively shopping for good programs, and we really do need evidence-based programs. I have come to be interested in suicide research in emergency department patients because of the work that I've done with suicide attempters, and that's the place where a population that we know is at high risk of suicide can be recruited. I think there are, from the work I've done, I think there are a number of relatively cost-effective programs that we can do with people who make suicide attempts. And that it doesn't have to be CBT programs or problem-solving therapy, which are 6 or 7 sessions, most of which these people don't keep, which it's cost ineffective to offer those programs to everyone as if one size fits all. And it's been my experience that often just a simple contact, keeping in touch with these people, sending, I did a caring letters project, a postcard project. Halfway through I realised it wasn't the appropriate medium any longer, we really needed to be sending them text messages. But they were incredibly grateful and very supportive of this minimal contact. And all it indicated to them was that someone in the hospital actually recognised that it was a hard time for them and followed up. Even it was a minimal follow-up, just a cyclist-style note saying, "Hope you're doing well." And it just brought home to me that the simple issue of connecting and caring was potentially as effective as some of our much longer, more expensive programs. So I'm interested in doing that sort of work at the moment, but I think that that has to be folded in with a complete program. And I think the opportunities for doing that, perhaps initially, the best opportunity is in an area which is geographically constrained, so that and small enough so that you can actually have contact with all of the players and try to engage everyone at all levels. And that's why the Zero Suicide program appeals to me at the moment, because there is evidence from various sources, and I'm thinking of Ulrich Högel's program in Europe, which has shown that if you have a multi-level program, it can make a difference. And also the Air Force program with, again, multiple components. I think the key difference, the move we have to make is away from focusing on just single programs to incorporating a number of programs into a multiple effort, a programmatic effort around the whole community. So that's what I'm interested in currently. We know from all the risk factor research that there are multiple domains of risk factors which contribute independently and via a common pathway of mental illness to suicide risk. So it makes sense that focusing on just one of those domains isn't going to be the whole answer for suicide prevention. And I think that with something which has multiple pathways and multiple causes, that we will get our best gain in suicide reductions if we focus on suicide prevention initiatives that hit a number of these different risk factor domains, with each of them making perhaps a small contribution to suicide reductions, but the combined effort will add up to a sum that's greater than the individual parts. So I think that that's really very important, and it fits with what we know about the multiple pathways to suicide prevention. The other point that I think we have to be aware of is that suicide is one outcome of a whole range of disadvantageous outcomes which have common risk factors. And so if we address problems such as alcohol abuse or social disconnectedness or early termination of education or teen pregnancy or problems with the justice system, if you look at all of those outcomes, they have common risk factors in terms of childhood adversities, disadvantageous backgrounds leading to sort of early mental health problems. And suicide is the most perhaps compelling outcome of those backgrounds, of those outcomes. But if you address the whole range of common risk factors, then you have a chance of reducing the populations at risk. And if you reduce the total population, then hopefully you will reduce the risk of, if you hit all of those risk factors, you will reduce the population at risk of suicidal behaviour. A small area within New Zealand, the region is called Canterbury, and the major city in Canterbury is called Christchurch. And it's a population of about 450,000, and it has a single emergency department and a single hospital system, which I think offers many advantages for a trial of this sort of zero suicide program. The city itself really can be regarded at the moment as a post-disaster community because it's suffered a number of major earthquakes and thousands of minor earthquakes over the last 2.5 years. And I think that that's provided us with an opportunity at this time where people have come together to try and support the city and its inhabitants through this disaster. But the advantage of that is that mental health services and health services have become united in a way that they might not otherwise have been. And I think that it's very timely if we are to go into health and mental health systems with a program to focus on suicide, given that there is an expectation that after a disaster, mental health problems will increase, and that includes suicidal behaviours and suicide as an outcome. So I think it's timely and opportunistic, if you like, but very often that's the best opportunity that you have. So as I hope this will evolve, I'm hopeful that we can engage and have good contacts within health systems, which includes primary care, the emergency department, as well as mental health systems in terms of both inpatient and outpatient services. And I would add into that school programs, programs for elders in the community, programs for first responders, for police and others. And I mean, and as a background against that, I hope we can do depression awareness programs. There are national depression awareness programs. I think we should tweak them for the local community and amp them up, given it's a post-disaster community. We also have lifeline services. New Zealand has the advantage of very high penetration with cell phones. There are more cell phones than there are people. So and that people are very technologically sophisticated. I've run some pilot programs on following people up with text phone messaging. I think we can do a lot, which is very cost efficient. There are another couple of advantages. Everyone in New Zealand has a unique National Health Index number, an NHI number, which means that you'll get from birth and it follows you through. That means that you can actually track suicide attempt presentations or any medical presentation, any hospital admission, hospital outpatient, visit to your general practitioner, primary health care practitioner, and you can match that against a mortality database, national mortality database. You can match it against a justice system database, an education database, and a prescribing database. So I think that there is potential to do a zero suicide program as a sort of a real community effort at suicide prevention, and look at outcomes with good databases as outcome measures. I'm very impressed with what particular states have done. I'm eagerly waiting to see what the outcome is. I'm very encouraged by the results of the pilot programs. I was left thinking, if this is all it takes, which it rests very largely on gatekeeper training, as well as the other programs. But if that's its base, we should have been doing this a long time ago. I think that what I hope is that other people see the various states that have taken this up as an initiative, see it as a demonstration model and are keen to replicate it in their other states. I'm very keen to see results as soon as possible. When I was doing my research project, we just did research, but we went out and we did our follow-up interviews wherever people wanted us to conduct them. And I literally have done follow-up interviews under a bridge. But every patient said to us, if mental health services put as much effort into finding us and following it up with us and coming to interview us in our homes as the research team has done, we'd have no complaints about mental health services. And that's always stayed with me, because I think you have to use the medium and the approaches that the patient wants. And for too often we've been office bound in the delivery of health services, and it's also been incredibly expensive. And in the future, we know we're not going to have a sufficient volume of mental health workers or sufficient funding to cope with the demand. And this is going to face everyone around the world. So it makes enormous sense to me to use whatever methods we can that are cheap and cost effective. And if sending a text message means it's a relatively simple, relatively enormously cost effective compared to training people in CBT and offering 6-session courses. If that, and I'm very interested in doing a trial and seeing what the relative cost effectiveness and efficacy of these, comparing these two approaches, because I think that we can do a great deal in terms of relatively minimal contact compared to what we've been doing. Right. So a text message, follow-up phone calls. I think it has to be bilateral so that it's not just pushing out to these people, but it's a push and pull situation. It's got to be bilateral. We've got to provide people the opportunity to call us and we can call them. But it can be done via the current communications technologies. And in fact, when I've done pilot studies with this, people have said, I don't know why the health system has been so slow to do this. My vet sends me text messages, my hairdresser sends me text messages. And it makes sense to me. That's how I do my communication. And when I've introduced this to staff, they've said it's so much easier to keep in touch with our clients. We now no longer see them coming to us when they're in trouble, but we can quickly flick them a text and say, how are things doing? The other thing is that people don't have landlines these days and they don't necessarily answer phone calls, but they'll read texts. So sending texts is very important. One final thing, we may have to be gender specific in what we do, because in my pilot projects, if I send a text to a male, I get a response immediately. And I've said to them, you're the fastest responder I've ever met. And he said, I'm a guy, this is what I do. You send me a text, I'll send you a response really quickly. That's to our advantage. Right. The women want to chat. And when I've sent them a text message and they've responded, they've said to me when I've rung them up and talked to them in terms of getting responses back about the potential of the program, they've said, oh, I was so disappointed that you didn't want to chat. So men will, if you say to them, how are you doing today, on a scale of 1 to 9, etc., tell me how you're doing, they'll respond with a digit. The women will respond and say, 3, I'm not doing so badly, but yesterday I went to see my doctor and now I have an appointment to be seen in a week. I think we have to be responsive to the way they like to communicate. With our Caring Letters project, we sent just a simple cyclostyled, I'm embarrassed about it now, but a cyclostyled sheet. But it was signed by the Chief of Psychiatry and the Chair of the Emergency Department. And it was interpreted by the patient as these people cared about what happened to me. That was very much their interpretation. And they came, they wrote letters saying, thank you for asking. And they came in with gifts for the people in the emergency department who said, we've never had patients walk in with a letter in one hand and a box of candy in the other saying, thank you. I think that's all about caring, and I think that it's incredibly important that that's what we focus on in the future.